Okay, I'd like to welcome everybody to my esteemed colleague, Colette Koulianos, who's going to talk to us about the Accumulator Adjuster Maximizer, HTC Sustainability, and Patient Access, and all the work that we at NHF have done to ensure that the HTCs remain sustainable and patients have access to the services they need when they need it and how. And with that, Colette, I'm going to turn it over to you.
No pressure, my esteemed colleague, Marla. I will say back at you for that one. Thank you. So thank you all for sharing your time with me this afternoon, and I hope you find the information beneficial. So without further ado, I will get started since our time will be limited and time flies when you're having fun. So our talk title is a mouthful. Accumulator Adjuster Maximizer Programs, HTC Sustainability, and Patient Access. So just a brief outline of what we'll cover here today. I won't sit and read them all, but this is an outline in case Marla's sharing the slide deck later. So CCSD. Hopefully by now you guys have heard about CCSD. It stands for Comprehensive Care Sustainability Collaborative. It's an effort that Michelle Rice and the team at NHF, which Marla was part of back in 2014. It's payer-provider kind of collaborative where NHF facilitated bringing the payers and providers together to have conversations about managing hemophilia, understanding the benefits of the hemophilia treatment center, understanding that they're the gold standard of care, and talking about how they can be assured that patients are being managed at the optimal total cost of care with optimal patient outcomes. And there's no one better positioned to do that than the Hemophilia Treatment Center. However, largely, most of you probably already know, payers are unaware of this fact. Not surprising because most of you guys also know that you don't bill for most of the services that you provide as an HTC. So all the ancillary components of a patient's visit, the visit with the social worker and the lab tech and the PT and the nurse, the physical therapist, all the other folks that meet with the patient, the dental team, whoever that might be, they're all provided as a service as part of the comprehensive integrated care model, but payers aren't billed for those services, so they're unaware that they exist. So what we wanted to do was make sure and reestablish the fact that HTCs are the gold standard and what all is being provided by hemophilia treatment centers with payers. The effort started in 2014, as I mentioned. I was asked at that time when I ran a hemophilia treatment center in Peoria, Illinois, if I would join as an advisory board member, and I was fortunate enough to get involved from the first meeting. And in 2016, I joined NHF. So this March 1 will be my 5-year anniversary with NHF as I continue to move the CCSD work along and obviously deal with any payer issues that threaten access. So we found out early that there was some conflicting priorities between payers and providers. Providers understand that payers have an ultimate fiduciary responsibility that HTCs don't have. Payers are squeezing the margin as much as they can, right? Because they're for profit and they have to answer to a board of directors or to their CFO or depending on the size of the company. And so they're always looking for ways to squeeze the margins. Much of that is done through utilization management, which you guys are all probably all too familiar with at your HTCs. It causes quite a burden and stress on the HTC staff. And HTCs rely on the margin that they receive from the 340B program for the patients they serve to fund their programs. Largely, that's how they're funded. And again, without the knowledge, understanding what all an HTC provides, a payer would be none the wiser. They're like, hey, I've got them in my medical network. I don't know what the problem is. They don't understand that all of the work that you guys are doing is funded through that 340B mechanism. So more and more we hear about HTCs being carved out of the network. That let's say it's a self-funded plan and they say we're no longer going to allow the HTC to serve the member. They have to use our own wholly owned for-profit specialty pharmacy to get their clotting factor. That puts HTCs at risk. Now NHF cares because NHF, if you don't remember, back in the 1970s, before 1970, the average life expectancy of a hemophilia patient was under the age of 20. Now, why? Because patients were dispersed throughout the country and one provider may see one patient in their career. So there wasn't research being done, there wasn't advancement in caring for patients because there wasn't a common platform in which care was delivered. So NHF petitioned Congress to establish a network of centers that would subspecialize in managing hemophilia. In 1976, Congress established the HTC network, and as a result, patients largely live a normal life expectancy today. I think in great part to the overall comprehensive integrated care that's provided at the HTCs. Obviously, prophylactic therapies and better treatments are playing a part as well, but fundamentally, at the core, we need the expertise of the treatment center. We're looking at what were the opportunities of bringing these folks together. So for providers, since they're getting carved out of network, it's alerting payers to the Center of Excellence model that's being provided there. It's walking them through how a patient is cared for. It's all the touches that happen in a year. Looking at the synergistic opportunities to collect data to make sure they deliver on maximizing the total cost of care at the lowest possible total cost of care optimal outcomes. And then understanding that even though there's negative attention on 340B in our country today, that the hemophilia treatment centers were original covered entities back in 1992 when the Veterans Healthcare Act was written, which is what 340B is. And as original covered entities, they've had oversight since then, unlike some of the newer programs that have come online over the last several years that have no oversight and have caused much of the ruckus about 340B centers. So we want to make sure that we distinguish the difference between hemophilia treatment centers and those other newer entities, covered entities. How can CCSD assist HTCs? We continue to advocate for HTCs and their pharmacy programs. Again, largely the medical component of the HTC is not affected. I mean, most patients can go to an HTC provider, except in California. I know, like in the Kaiser Health Network, once a child ages out at 18, they're generally not allowed to see an HTC. So barring that scenario, most other plans do allow patients to see a medical provider at an HTC. Again, the problem is with the pharmacy. We're also looking at other opportunities to supplement revenue within the programs, such as telehealth, right? So some centers had already up and established their telehealth programs before COVID, but COVID has prompted the rest of the centers out there have likely had to do a crash course in telehealth provider visits at no fault of their own because of the pandemic. And then gene therapy. Gene therapy has got people losing sleep at night. The payers out there are literally saying, I don't know how in the world our current payment model could ever pay for these $2 or $3 million, which is, again, that's hypothetical. We don't know what the cost will be for the first gene therapy that comes out, but that was the talked about amount. How will we ever pay for something like that when we have the challenges of patient mobility? In other words, they may not be on that plan much longer after they get the gene therapy, so that they're going to pay the big price tag, but they're not going to get the benefit. And how will they track the data to make sure that the patient is getting the expected outcomes that the plan expects for making that kind of a one-time out-of-pocket cost? And so there's all these challenges. And again, once again, it's an opportunity that we have to look at it as of reestablishing the hemophilia treatment center as a center of excellence, not only for everyday care of the patient, but also when gene therapy does get FDA approval, that's where the patient should be seen pre, during, and post-infusion. So these are the opportunities that we've continued to work on and will continue to do so. We formed an HTC Advisory Group actually to do just that. We were bringing HTC clinicians. The first phase was bringing the clinicians that had done gene therapy trials together to talk about some of their experiences during the clinical trials, what HTCs would have expect as far as time commitment to identifying patients who would qualify, to the day of infusion time commitment, to mixing, freezing, then thawing and mixing, and in a clean hood, clean room, potentially, depending on if it's rated biosafety level 1 or 2. And then the actual infusion, how long will they be expected to stay, et cetera. And then the post-infusion follow-up, the short term, which is going to be heavy follow-up, And then for 6 months, maybe a couple times a week, blood draws. And after that, maybe once a week. And again, it'll filter on who's going to report the data. So we learned from the HTC providers that were most heavily engaged in gene therapy research. And then we broadened the group to those all HTC providers who've done any gene therapy trials or who are expected to be a gene therapy administration site based on their capabilities. And so now we're coming up with a checklist so that the centers will be prepared when that time comes. So who are we targeting? Well, the biggest issue for HTCs, I'm sure you guys know, is self-funded employers. Because when a self-funded employer, they use a TPA, a third-party administrator, like a Blue Cross Blue Shield or an Anthem or an Aetna, to administer their benefits, but they pay the claims. And then they would use a PBM to administer their pharmacy benefits. As I said earlier, many TPAs now own PBMs who own specialty pharmacies. If the TPA doesn't own the PBM who owns a specialty pharmacy, the PBM owns a specialty pharmacy. In either case, of course, in that scenario, they're recommending to the self-funded plan, let us manage your entire book of business, give us all your specialty drug spend, and then we'll give you a discount on all of your drugs. And so they make it so it sounds very promising, and the only way to get that is to give them exclusivity, and hence that's the problem that we have today. So we target that to educate employers about the reality of that scenario, about monopolies not being in the best interest of the purchaser of healthcare. We're trying to help HTCs develop resources and tools to use when they have dialogue with payers. I was on a call with Jennifer Barillo earlier today, and she said, you know, as an HTC, we educate and we teach our patients to educate and advocate for themselves. So the chapters that are on here, I'm sure you can relate to that. The HTCs that are on here, you can relate to that. But HTCs need to learn how to educate and advocate for themselves when it comes to payers. And that's what we're trying to do in developing tools and resources in conjunction with our friends at the Hemophilia Alliance, who are also out there with a large contingent of staff working to make sure HTCs are in the network as well. So that's an overview of CCSD. I could spend the whole hour talking about CCSD, but then we wouldn't get into copays accumulators and copay maximizer programs, which I'm sure you guys are all chomping at the bit for me to discuss. So without further ado, I've said it before. Only thing I did today is I'm changing the look of the slide. Where are we? We still have a basic challenge in our country as we come up to open enrollment, or as a result of COVID, because so many people in this country lost employment due to COVID, and they might have had no other option but to jump on a plan on the marketplace. They look at all this stuff and they have no idea what the terminology means. They have no idea how to select a plan. Marla's always been great at updating the toolkit and providing those resources to our community, but largely it's a disconnect in understanding the basic terms. So what do we know? We know that patients first look at, I bet if I said guess, everybody would jump up and say cost, and you'd be right. So the very first thing patients look at is the cost of healthcare. And so when they're selecting a plan on the marketplace or even an employer plan that's offered, they get options. They're looking at the lowest premium because that's what they have to pay. Now, if it's an employer sponsored plan, that means the employer pays a portion of the premium and the employee pays a portion. They still have to pay a portion. So they're looking at how much money do I make? I have all these costs in life. I can't afford more than, I want the lowest premium. But lowest premium isn't always best because, as we know, that the lower the premium, the higher the out-of-pocket cost. So the premium doesn't make up your out-of-pocket cost, all right? Out-of-pocket maximum that you have every year is made up of three things. That's your deductible, your copays, and your coinsurance. So first, you pay your premium to get health insurance. If you stop paying, you lose your health insurance. Now you have your health insurance. If you have a deductible, any amount, you must pay the deductible in its entirety before the plan first pays the first penny. So if you're in a high deductible health plan, that means your deductible could be all the way up to $7,000 in 2021. And so you would have to pay the first, if you had a $7,000 plan. Now there's lower deductibles that are still called a high deductible health plan. That's the max. Whatever that dollar is, it's anything over $1,450. So anything over $1,450 on for an individual is considered a high deductible health plan. So they would have to pay that in its entirety before the plan started to pay the first penny. Now the deductible's paid. Once it's paid, then they have copays and coinsurance. Most people know what a copay is. It's an identified amount of money you pay at the pharmacy, depending on what tier your drug's in, or if you're seeing a primary provider, it might be $25, specialist might be $50. You might have a copay for an emergency room visit, etc. But first you pay the deductible in its entirety, then you do your copays and coinsurance, which means some shared amount. It's usually 80-20 with the health plan. So once you've met your deductible, you have your copays, you have your coinsurance until you meet your max out of pocket. Now, I'm going to go into the max out of pocket here in just a moment for 2021. I'm going to talk about real quickly accumulator adjustment programs and maximizers, just define them to say, in case there's somebody on here who may not know. And I hope that by now we all, for the most part, have an understanding. An accumulator adjustment program says that you can still use the assistance that the manufacturers offer, such as manufacturer copay cards, but that doesn't count to your accumulator. Now, what's an accumulator? Your accumulator is your accumulated out-of-pocket that you yourself pay, or if you're a parent, you pay on behalf of your child for your health care until you meet your deductible, and then your copays, coinsurance to meet your max out-of-pocket. So before copay accumulators, before 2017, if you used a manufacturer assistance card, that went towards your accumulator. And so for many patients in the hemophilia world, you could have gotten that fill on January 2nd, hypothetically, and it would have met your annual out-of-pocket spend just on that first bill using that copay card. It's something that our community relied on because for many, that's a lifeline to accessing their treatment and their care. So with copay accumulators, you're saying, oh, no, keep using the card. But once you've exhausted the value of the card, then you have to meet your out-of-pocket responsibility. And I'll go into how that looks. I'll walk you through an example here in a moment. A maximizer, the difference is with a copay accumulator, and you'll see in the example, once you've maxed out your copay card and you hit the maximum value and it's done for the year, you have to pay the entire deductible. So it's like a cliff. So as soon as that's maxed out, you have to pay that whole deductible. Remember, it can be anywhere from $1,450 to $7,000. So if you hit anywhere in that range, you got to pay that whole thing before they'll dispense your drug. It's like holding your drug hostage at the pharmacy counter. With a maximizer, it's more complicated and even more confusing because, as some of you I know on this line know, because I've helped you with this, they call them clever names, just like they do with the copay accumulators. But it essentially means they take the manufacturer's value of their card, they adjust it out over 12 months. So if it's a $12,000 copay card, then they're going to take that drug out of your normal formulary and plan design, and they're going to say, for that drug, your copay is $1,000 a month. And they're going to use that copay card every month throughout the year, and you'll never have that cliff where you can't get your meds. However, none of that counts to your accumulator. So any other healthcare expenses you should have or any other medications, you're going to have to meet your deductible out of pocket. So it's still the better of the two evils. You know, if I had to pick one with a gun to my head, I would say maximizer I'd rather for our patient community than an accumulator, but I don't want either, right? Because that's just simply, especially in light of COVID and the economic impact of COVID. I talked about the misleading names. Well, here's just a few little examples of some of the names these clever insurance plans have come up with for copay accumulator adjustment programs. Express Scripts calls it out-of-pocket protection program. Caremark, True Accumulation. United Healthcare Coupon Adjustment, Benefit Plan Protection Program. Now, those are just a few, but if people don't understand the basic healthcare terminology, which, by the way, 91% of our country does not understand those basic terms, deductible, copay, coinsurance, out-of-pocket. They don't understand the premium counts they're out-of-pocket. So how are they going to understand what these mean? Whole different ballgame. And where would they even find this in the plan language? That's been the challenge. So let's talk about the out-of-pocket limits for 2021 because we're almost here. So in 2021, if it's a non-grandfathered ACA compliant plan, The maximum individual out-of-pocket is going to be $8,550. So it went up $400. The maximum family out-of-pocket is, of course, doubled the individual. That's $17,100. So you can't make an HSA contribution if you're in a non-grandfathered ACA compliant plan. That's not a high deductible health plan. So that's not applicable. So let's look at an HSA qualified high deductible health plan. So that's a health plan that has at least, remember, $1,450 deductible or higher for an individual, or double that for a family. So if it's an HSA qualified high deductible health plan, meaning the $1,450 for an individual, then you can put money in pre-tax into a health savings account and use that to help pay your out-of-pocket expenses pre-tax. Okay, so the problem is, take a look here. So in 2021, the max individual out-of-pocket for a high deductible health plan is $7,000. The max HSA contribution, $3,600 for an individual. The max family out-of-pocket is $14,000 for a high deductible health plan. The max family HSA contribution is $7,200. So clearly, what you can actually save in your HSA account falls far short of what your max out-of-pocket could be. So that's part one of the problem. Part two is with an HSA, unlike a flex plan or cafeteria plan or Section 125 plan, where the company puts them in and you put them in, or you put it all in and the company guarantees it. It can be January 2nd of the year. Let's say you decide I'm going to put away $2,000 this year into my flex plan, pre-tax. January 2nd, I haven't even made my first contribution yet. I need to take all that $2,000 out. I can technically use it before I ever saved a penny. And if I quit my company, my employer's on the hook. That's why they usually cap it at some couple $1,000 range. So with an HSA, you can't take it out until the money's saved. And we all know that in month one, year after year, with hemophilia patients and most chronic disease patients, the cost of the drug is going to require them to expend the entire deductible the first month when they will not have any of that saved anyway. So multiple challenges with this. And it's important to know that when you're talking to folks and you're trying to fight against these programs. And I like to say the dollars and cents, SENs, it doesn't add up. So let's look at somebody living with chronic disease. Okay. First of all, this is everyone, not even chronic disease people. In our country in 2019, the median household income was the highest it ever was. It was $68,703. That was the median household income. It went up from the year before by almost $7,000. Okay, now with COVID, we know 49% of the American population have actually said that they've had a decrease in income due to COVID. So I don't know what this year is going to turn out to be, but even in a perfect world, if we were back at 68,703, which I'm assuring you we won't be next year, the individual max out of pocket is $8,550, family max $17,100. Now, when asked in a survey how Americans would pay $1,000 for an unexpected medical expense, and you look at the graph here, they would 41% say they would take it from savings. Majority of the rest of the folks either couldn't get their meds, would have to finance with a credit card, would have to reduce something else in their house, because those out-of-pocket costs taken from that median household income, remember the premiums on top of that, your house, your kids, your car, your school, your clothes, your food, all of life's expenses come out of that median household income too. So the numbers and cents do not add up clearly. All right, so how many people are affected? This started in 2017, the first plan implemented this. We identified it in late 2016. From then to today, 60% of lives that are on a commercial plan have an accumulator adjustment program in effect. That's a whopping number in this period of time, right? In 4 years, essentially, starting January. And then many others that are saying that they're looking at implementation. So there's a huge challenge here, and why we have continued to fight this as aggressively as we have. I helped start the AllCopaysCount Coalition. We have MS, cancer, Kidney Fund, Arthritis Foundation, and AIDS Institute. And NORD was part of the original steering committee. Since the person at NORD left and no one stepped up in that role. But so that makes up the steering committee. We have nearly 80 or 80 plus now members of the coalition in our broad membership. And the goal is together, we all represent chronic disease, millions of lives. And we believe that CAPS, copay accumulator adjustment programs, impede access to care and urge measures to assure that copay assistance is allowed to benefit the patient, which is who it's intended for. So that's what the purpose of the coalition is, and that's the work that we're doing in that group as well. We found out October when the plan bulletin came out for United Healthcare, the very first of its kind accumulator adjustment program rolled out on the medical benefit. Now, United Healthcare rolled this out on the pharmacy benefit. Anyone in the United Healthcare network that had to use Optum and Briova, this was already rolled out almost 2 years now. But any patient being served on the medical benefit, in other words, the clotting factor being billed on the medical benefit, this is now an obligation they're putting, because they couldn't really implement this before, because they couldn't figure out how would we ever be able to track whether a patient used assistance for their medical on a medical benefit. How they've done it at United is they're requiring the providers to attest to whether the patient used the copay assistance. So of course, the AllCopaysCount Coalition jumped into action. We've jumped into action. We're not okay with this. I did have a call with United Healthcare, and so the update on this is a couple things to note. Right now, for patients with hemophilia that see a hemophilia treatment center, there are a large number of patients that are seen at one of 20, maybe a little over 20 hemophilia treatment centers in the country that actually have a United Healthcare contract and are able to serve patients on the medical benefit. If the patient goes to one of those centers, so if your center has a United Healthcare contract to serve clotting factor on the medical benefit, and you have some sort of patient assistance policy in place. In other words, at BCDI, the center I ran, we would, in January, our social worker would resend out the paperwork to our patient families, and they had any number of criteria. If they met, then they qualified for any assistance. It doesn't matter how high and robust you make the threshold. I mean, you could say, if you make under $1 million a year, I'm just making that up, but you can, whatever your policy is, as long as you're looking at, because hemophilia treatment centers are nonprofits, United Healthcare said that if they've gone through that policy, then they would not enforce this with the patient seen and getting their clotting factor from the hemophilia treatment center. So that's great news for those patients. However, not every patient goes to a hemophilia treatment center that has a contract. So still have work to do here. Michelle Rice was instrumental in helping back when I was at the center with getting this contract in place with HTCs and United Healthcare, and we've continued to have a good relationship with them, albeit there is some billing problems and issues out there. I'm not going to deny with United Healthcare, some of it's on them, some of it's Optum, and so we continually get pulled into working on those issues. But for those centers that have a hemophilia treatment center contract, if you have some sort of patient assistance program in place, you don't have to report it. You can still get the coupon from the manufacturer, use it to the patient's out of pocket, count it to the patient's out of pocket, and call it a day. For those patients who cannot use their hemophilia treatment center but have to use Briova's pharmacy, well, this was already in place before. So it's not really going to change for that. So in our world, in the hemophilia world, there's that. They are rolling it out in phases. So if a state has an anti-accumulator bill, they won't put it on the marketplace plans in those states. When United Healthcare rolled it out on the pharmacy benefit a couple of years ago, they rolled it out to all the self-funded employers as an opt-out, which is a bad thing for us, because that means that every one of their clients who are self-funded, which is over 60% of United Healthcare's business, every one of them, we're going to have an accumulator adjustment program on them unless they called and said, take that off. So United Healthcare told Michelle and I at a meeting we had with them in 2018, we can't tell you how many removed the deal, but we can tell you it was very few. So for the large part, we know that 60+% of United's business is ASO business, meaning self-funded, and that was an opt-out. So largely they all kept it. one of the reasons why the numbers of accumulators are so high. So the new medical benefit deal, they're rolling as an opt-in. So I don't like it, but it's better than an opt-out. That means that those self-funded employers have to say, put me in that program, as opposed to take me out. So they have to make a conscious decision. I have no doubt there'll be many who will ask to be put into the program. If you listen to what United says, all the self-funded employers are clamoring, saying we must put this program in place on our plan. So we'll see how that works. But they're going to roll it out in phases. The self-funded plans will be rolled out in the spring. They didn't give me an exact date. And once they start the self-funded plans, they'll be implemented as the plan year changes for those companies. So if you're work for a company and your plan year changes, let's just say in July is your new plan year, and they rolled it out in the spring, it's going to impact you. If you are on the pharmacy benefit, not at one of those HTCs, it will impact you starting in July when that rolls out, because it would have already been implemented in the spring. But if you're in one of those companies that your plan year starts somewhere January to, let's say, March through March, then it wouldn't start until the following time in 2022, because if they've already counted that to the out-of-pocket, it counts for that year. And they also confirmed that if a patient gets assistance from a third-party nonprofit, like PAN Foundation or PSI, or any number of whatever, HealthWell, the Assistance Fund, Patient Advocate Foundation, all right, if they get assistance from there and there's needs-based assessment because they're nonprofits, they will count that to the members' accumulator. So please keep that in mind. And for any pharmaceutical companies listening, please fund those programs, because we cannot let patients not be able to get their medicine. It's not the end all, it's not what we want as the ultimate victory, but until then, we can't have patients not be able to access their medications. So as you guys many know, in 2019, CCIO and CMS, when they issued the National Benefit and Payment Parameters final rule, it was in May of 2019 for the 2021 plan year. They said no health plan, and that includes self-funded, so it was a big victory for a minute. No health plan could implement a copay accumulator adjustment program if there wasn't a generic. So again, we were very excited by that ruling. However, that was May of 2019 for the next year. In August of 2019, it was walked back because there was a lot of people who are proponents of the accumulator programs jumping up and down, and they used the reason for walking it back was that it could be a violation of the IRS HSA guidelines. Right? Because if you put money into a pre-tax health savings account, the argument was, and then you're able to use this, then you're not, then it's against the guidelines of IRS. Now, listen, I'm not a lawyer. I'm not going to pretend I'm a lawyer. I challenge that because when the National Benefit and Payment Parameters 2021 was issued in May of this year, they said a plan can put an accumulator on if they want to. So if they're allowing them to put one on if they want to, it tells me it's not a violation of IRS HSA guidelines. It is not mandatory. So, and, you know, I use the argument, I see St. Jude commercials every day. Nothing against St. Jude, love the organization. But the commercials say no one will ever get a bill, regardless of your means. We'll collect just what your insurance pays, and the rest, gone. So they might have an HSA. Why is that okay? That's the rule as it stands today. We do have a bipartisan bill. The bill, I'm going to go to the next slide. It's HR 7647. That is actually, it's a congressional bipartisan bill. I'll be honest, right now, the number of sponsors, I believe, is, I want to say 32. 3 are Republicans, the rest are Democrats. But hey, there's 3 Republicans on there. I'm happy to hear that. And we need to get more of our legislators to sign on to this bill to make it move. What they're asking Congress to do is enforce and make CMS go back to the final rule 2020, which says no copay accumulators if there's not a generic until at least a year after COVID crisis ends. So while it's not the best of all worlds, like would be just let's eliminate these suckers for good, it buys us time. And so, you know, I don't know about you, but I'm certainly in favor of buying time and enforcing back to the 2020 rule. So if you have any relationship with any of your legislators in your state, your patient community, this is where they can activate and reach out and ask them to sign on to HR 7647. I already mentioned this. There's been large shifts in employer-sponsored health insurance coverage. As a result of that, back before January 2020, the payer mix in our country, we had about 50% of all people in the country were on commercial health plans. Of those people on the commercial health plans, 60-some% were on employer-sponsored health plans, meaning the employer paid some part of, 80-some%, some part of the premium and the member paid the other portion. The remainder of those were either on individual or family on the marketplace or bought their plan off the marketplace some other way. Okay, so everybody on commercial insurance. The rest of the people in the country, the rest of the 50% or just shy of 50% were on Medicaid, Medicare, TRICARE, or uninsured. So the largest chunk of any insurance pot, if you will, was commercial. And of that commercial insurance, 63% were self-funded. Okay, so the biggest chunk of any one category was self-funded plans. They're governed differently. They're governed by ERISA. So if a state has an anti-accumulator bill, they can't govern those self-funded plans and make them not put an accumulator on. It only works towards the ACA compliant plans, okay, or the small group plans. So it has to be an ACA, non-grandfathered ACA compliant plan. That's what state government can do. Well, because of this chart right here, why this is so important is because we lost so many people off employer-sponsored insurance, we know that more people were forced onto the exchange, which then means that states do have an impact. So the AllCopaysCount Coalition and us at NHF, we've doubled down our state work in trying to raise awareness and attention of this. So far, there are 6 states that have anti-accumulator bills. One, just recent, in case you didn't know about that one. So there's Illinois, Virginia, and West Virginia. They have similar language, although this model language is taken from Illinois. It's the broadest, it's the best. If we could have a perfect bill, this would be how it looks. No accumulator adjustment programs, period. Okay. And then in Arizona, they have no accumulator adjustment programs if there's no generic. If there is a generic and the member uses the generic but doesn't respond and needs to have the name brand, then there's caveats. So again, not as robust as Illinois, Virginia, and West Virginia, but certainly better than nothing. And so I would say this is the second best of the languages that are out there. And then the third one being Georgia, which is same exact pretty much as Arizona, except they go a step further and say, only if the health plan agrees to accept copay assistance. So they could choose not to accept it, and in that case, then this doesn't apply. So that's kind of the way these shake out. Puerto Rico is the most recent, and I was able to get that language translated in Spanish, but basically they're prohibiting copay accumulator adjustment programs in Puerto Rico. So good news for Puerto Ricans. So what are we doing at NHF? This is where the big, kind of rubber meets the road. We're doubling down on our state work, but we know that in order to truly fight against these, because many states, I've been on with my friend Rich Pizzillo in New England and at NEHA, where we talked to the state senator in Rhode Island who said, basically, show me the data, because the health plans are telling me that copay accumulator adjustment programs will save them money, and if they don't put it on, it's going to cost them more. So, and they also want to know about health inequities and disparities. They want to know how many people are impacted by this in their state. So we launched a 2-phase survey. The first phase was to the national public of registered voters. So you had to be a registered voter over the age of 18 to respond. And then the second phase is specific to the chronic disease community. Now, we haven't launched that survey yet. We're going back and forth on the questions on that one because we want other disease groups to push it out. Each group has to take it back to their leaders, and we have new language and we have to start all over. So I'm hoping within 2 weeks that'll be fielded, that it will be launched, and we'll start to get some data in on that. But the results of our survey were very promising. Here's the key takeaways. The most important healthcare problem for voters, and remember, this is registered voters over the age of 18, so take off your Republican and your Democrat hats. This is just squarely across both parties. The most important healthcare problem is cost of health insurance premiums. However, it's clear lowering premium costs cannot be resolved by higher deductibles and higher out-of-pocket costs for voters because they were ranked, second and third highest. More than 4 in 10 voters with chronic health conditions say they or someone in their household has not been able to afford their out-of-pocket costs over the past year. And when we take another subsection of this data and we look at just people that have one of the health conditions that our steering committee represents, so that would be HIV, hemophilia, MS, cancer, kidney, or an autoimmune condition, of those 6 condition or disease states, over 51% said over the last year they haven't been able to afford their out-of-pocket. And the majority of voters across political parties believe the government should require copay assistance count towards patients' out-of-pocket. So why is this so useful? Because this is what we're going to show the legislators in the states. This is what we're going to show the federal legislators saying. The voters have responded. Substantial majorities of voters believe that if the government does not intervene and apply and enforce that this assistance is applied to patients' out-of-pocket costs, it'll have significant negative consequences for people with chronic diseases. Now, I think what's so powerful about this data is that even though only, I think it was just shy of 30% of the respondents, and don't quote me exactly on the number, but of the respondents of this part of the survey, right around 30% noted they had a chronic disease. Now, it could have been, as I said, any chronic disease. They could say asthma or whatever. But then we took a subsection and asked of those 6 conditions. So even though only, around 30% had a chronic condition, overwhelmingly, the vast majority said if they don't count it, it could have detrimental impacts. So it's not just people with chronic disease who feel this way, it's all voters. And nearly half of voters said if they had a chronic condition and financial assistance didn't count, there is either no way they could access or afford their medications, or they would have to deplete all of their savings and or take out credit card debt. And again, remember, COVID is by the day impacting this even more negatively. Here's some of the results. So 86% of the respondents, that's of all respondents, said that they believe the federal government should intervene and make sure that the assistance counts to the members out of pocket. Now we look by party. Republicans, 83% strongly believe, or 53% strongly believe, 17% do not strongly, or say no strongly, they don't believe. But 83% of Republicans either strongly or somewhat strongly, I forget exactly how that was worded, I have to go back and look, said that it should count. And independents also 83%, and Democrats 91%. So if we set across parties, the correct way to communicate that would be over 83%, over 83% of voters across political parties believe it should count. Otherwise, it's just 86% of voters. The majority of voters believe there are significant negative consequences to not counting the assistance. And again, these are versus chronic disease versus non-chronic disease, and what would happen if it didn't count. I'm going to run through this really quick for those of you who haven't seen it, and for those of you who have, just bear with me a minute. Pretend John Doe is on a high deductible health plan, and his deductible is $5,000. And for the case of this, to make it easy, his max out of pocket is $5,000. Let's assume he's on a drug that costs $20,000 a month. The manufacturer copay card for his particular product is $15,000. Now, for the sake of this example, we're going to pretend that John Doe has no other healthcare expenses. It's just about his clotting factor for a moment. So before accumulator adjustment programs and maximizers, in January, when John Doe called his pharmacy and said, I need my clotting factor, you remember he had a $5,000 deductible. They used the manufacturer card, paid the $5,000, the insurer paid $15,000, the remainder, and the patient's deductible became zero. In other words, it was met. So from then on, every month after that, you see the insurer was exposed to the full cost, the $20,000, and the patient had no responsibility. Now, once accumulators were brought onto the scene, January, patient calls John Doe, I need my factor. They take $5,000 from the manufacturer card. Remember, I said it had $15,000 on it. On the back end, they adjust the patient's accumulator, which means his accumulated out-of-pocket expenses he paid to reflect only what he paid, which was nothing. So at the end of January, his accumulator shows he's paid nothing, so he still owes the whole $5,000. So February, mostly this is unbeknownst to the patient until they hit the cliff, but February, he calls for his meds. They take another $5,000 from the manufacturer card. They reset the member's accumulator on the back end. Then March, they take the last $5,000. Remember, it's a $15,000 card. They take the last $5,000. They leave the member with, so at this point, the card's exhausted, and they reset the member's accumulator. It still shows they owe $5,000. So come April, when the member calls, they say, how will you be paying your $5,000? And that's where the member, it's like, excuse me, well, you have a total benefit protection program on your plan. Remember those clever names? What the heck does that mean? That sounds like a good thing. Well, it's not. So, and then if the member, in a fantasy land, if the member in April had all $5,000 and could pay it, they would pay it. And then at that point, and only at that point, would it still show that they had, that they had a zero deductible. It's now been met. And with the maximizer, just to show you how that works, every month, if you use that same scenario with a $15,000 card, if I divide that by 12, every month, they would take another $1,250 from that manufacturer card, so that all year long, the member gets his drug. Where if we go back to the accumulator, if April, he doesn't have that $5,000, he isn't getting his drug. But in a maximizer program, there is no cliff. They're still going to get their drug every month because they've spread that coupon out over a 12-month period. But you'll notice that with a maximizer, all year long, that deductible is never paid down because that does not count to their accumulator. So if you compare the scenarios, the 4 accumulator adjusters and maximizers, once that $5,000 was taken the first month, the end of the year, the patient had zero expense. The pharmaceutical manufacturer only had a $5,000 exposure because once it was met, it was done. And then the total cost of the insurer for the $20,000 a month for the remaining months was $235,000. Scenario 2, using an example with an accumulator, month 1, month 2, month 3, they take the whole value of the farmer's card, pretending in month 4, the patient has the $5,000 for a minute. Now, after that, the insurer pays the full $20,000 from then on because now the deductibles that been met, it's been satisfied. So in that scenario, at the end of the year, the patient was exposed to $5,000, the pharmaceutical was exposed to $15,000, and the employer or the health plan was exposed to $220,000. So you see, before accumulators to after, if I'm an employer or I'm a health plan, it looks like this is a big savings to me. I just saved $15,000 on one patient. They're not thinking about the unintended consequences because most of patients, when they hit April, they don't have that $5,000. So the real fact is they're going to be forced to the highest cost of care setting, which is the hospital and ER. It's going to cost significantly more to the patient in health outcomes, but to the health plan because of a higher cost of care in those settings. And the maximizer, if we just take that coupon of value over the year, and the patient didn't have any other healthcare expenses, the patient would have had no expenses to their clotting factor. Had they had other healthcare expenses, they would have. But again, for the scenario, that's all we're looking at. The manufacturer would have, had all their card used, so $15,000, and so the plan would have spent a total of $225,000 in that scenario. So the best option, if I'm a health plan, looks like the accumulator adjuster. The next best is the maximizer if I'm the health plan, but that's very short-sighted, especially for hemophilia. So that's my last slide, and I'm gonna let Marla jump in and I guess ask me my questions.
Yes, and in theory, I think everyone can hear me now, hopefully. Okay, so Lisa Cohen had asked, can an employer who contracts with United, who opts in for the accumulator, choose to opt out for a particular employee? And has this ever worked to advocate with the employer to do this for a particular patient?
Yeah, so they can't just opt out for one patient. They have to do it across the board. But it has worked. We've been successful in either getting them to just reverse the decision, or we've gotten them to move the hemophilia drug onto the preventative drug list. With some of the largest jumbo health plans in the country, we've had success. Once we give them the whole kind of true picture, the unintended consequences, If they shift the drug over to the preventative drug plan, that's first dollar coverage, so it's outside the deductible. It's much like the maximizer in that they'll get that drug right away, first dollar. The one who benefits in that scenario is manufacturer isn't exposed to that $15,000 cost, but the patient's still exposed to their deductible for all their other healthcare expenses. So it's much like that example.
I would add to that, right, that there's also, if it is a self-funded employer, right, like you have to work with the self-funded employer, which means you have to be comfortable with having the patient talk to their.
Right. And I would recommend that if any of you have patients who are willing to have that conversation with their employer, right? Because you first have them worried, we keep hearing more and more patients are afraid to, raise the ruckus, especially with the economic impact of COVID, because they don't want to lose their job or identify themselves as being a high cost claimant. But if they're willing to do that, the most important advice you can give them is not to say, this is going to be such a burden, I'm going to have to quit my job. Because I have to promise you that for a lot of employers, they'll act sad, but on the back end, they'll be doing jumping jacks, right? Because if they can do something to help eliminate paying for your claims, then it's a win. So the best thing you do is say, by implementing this plan, I don't know if you understand how important my drug is, and there's no way I can afford this. So I'm going to be forced when I get off work multiple times a week to go to the hospital, to the highest cost of care setting. It's going to cost you guys a lot more. That's the conversation they need to have with their employer.
And Rich had asked, did United Healthcare say that all plans where treatment is billed under medical will 100% enroll an accumulator adjuster, or did the letter state that they're allowing them to do so? We received a lot of community members who have coverage under United who are freaking out that their plan will have.
So first you have to ask the question, if you're in a state that has an anti-accumulator bill, they will not roll it out on the HSA compliant plans in the marketplace. But if there is a self-funded plan in that state who doesn't have to abide by the state legislation, that plan can implement it if they want to. It's not an opt-out, it's an opt-in. So they would have to say, sign me up, but they can, which is why federal legislation like that bill I said we need to get supported is so important, because that's the only true way to stop it across the board, whether it's an ERISA plan or an ACA compliant plan. But they are going to roll it out to the small plan, then roll it out to the large plans and to self-funded. Now there's a list that are being excluded, at least for now. Oxford, for example, is excluded, I believe, on the list. Some out west, I want to say Colorado. So I'll share it with Marla to share out with the group. I'm sorry, I should have put it in here so that you guys can see which United products will not roll it out.
And with that, we are at time. And I wanted to thank Colette. I want everyone to thank Colette.
Thank you guys so much for your time. And Marla, for all your work.
Bye, guys.
Bye, y'all.